If you've ever been called double jointed, or you're just wildly curious about how the human body works, you are definitely in the right place today.
Yeah, we are getting into some really fascinating kind of paradigm shifting territory.
We really are, because our mission for today's deep dive is to explore this highly surprising sort of hidden connection between hypermobility and pelvic floor health.
Right. We're basically going to be untangling what specialists in the field call the hypermobility paradox.
Exactly. And we really want to answer one specific, highly debated question. Does being hypermobile inherently increase the risk of symptom recurrence after you undergo pelvic floor treatment?
Which is such a critical question, because the whole medical field is finally starting to realize this isn't just about being bendy or having a trick knee.
All right, it's systemic. And to give you, the listener, a really clear picture of this, we're pulling from a pretty specific stack of sources. We've got the clinical guidelines from NICE, that's the UK's National Institute for Health and Care Excellence. And we're pairing that with surgical outcomes studies from the Canadian Urological Association Journal, plus expert insights from the Ehlers-Danlos Society. So we've got a lot of heavy-hitting data here.
We do. And before we can even touch on treatment failures or recurrences, we really need to establish what's physically happening inside a hypermobile body.
Okay, let's unpack this.
Yeah.
Because it's not just a party trick, right? It's a fundamental issue with how the body builds collagen.
Exactly. So with conditions like Ehlers-Danlos syndrome or EDS and hypermobility spectrum disorders, the actual genetic blueprint for collagen is altered.
And collagen is basically everywhere, right?
Well, it's everywhere. It's the primary structural protein in your whole body. It gives strength to your skin, your blood vessels, and critically for today's topic, the fascial web and the ligaments that hold your pelvic organs up.
Right. So the analogy I keep thinking of is it's like building a house, but the mortar holding the bricks together is made of rubber instead of solid cement.
That's a perfect way to visualize it.
Every system that relies on that mortar is going to be in a constant struggle with gravity. And this is way more common than people realize, isn't it?
It really is. I mean, one of our sources, a recent population study out of Wales that looked at like 1.7 million health records, found the diagnosed prevalence is hovering around 1 in 500.
Wow. 1 in 500.
Yeah. So we are not talking about some rare, esoteric medical anomaly. It is a very widespread, underdiagnosed reality.
Which perfectly sets up this wild contradiction we need to talk about, the hypermobility paradox. Because if the mortar is rubbery and the ligaments are loose and stretchy, you would logically think the pelvic floor muscles are just weak and floppy too.
You would think so, yeah. But the clinical data shows the exact opposite.
What's fascinating here is that the human nervous system is incredibly pragmatic.
Right, your brain realizes the passive stabilizers, those stretchy ligaments holding your pelvis together, are basically failing. They aren't providing tension.
So the body panics.
Exactly. The autonomic nervous system hits the panic button and forces the pelvic floor muscles to act as emergency stabilizers. They have to work overtime just to hold your lumbar and pelvic joints together.
So they're doing a job they were literally never designed to do.
Never. And they're doing it 24 hours a day. So this chronic guarding leads to a hypertonic pelvic floor.
Meaning it's overactive and won't relax.
Yes. And the numbers on this are staggering. We're seeing this high-tone, non-relaxing dysfunction in about 63% of patients who present with chronic pelvic pain.
63%. That is wild. And this constant tightness actively mimics weakness.
Right.
Like the muscles are so exhausted from clenching that they just fail when you need them.
Right. And it causes severe symptoms. Intractable constipation, urinary urge incontinence, and the pain metrics are incredibly high. Up to 64% in one EDS survey reported dyspareunia, which is painful sex.
Okay, wait. I have to push back on the standard medical advice here then. Because if a patient goes to a doctor and says, I'm leaking urine, the standard advice is almost always, oh, do your Kegels.
Oh, practically uniformly. Yes.
But if their muscles are already clenched like a literal fist just to compensate for loose joints, isn't prescribing Kegels actually going to make things so much worse?
It is going to make it significantly worse. It just accelerates the muscle fatigue and drives the pain up. But what's fascinating here is why this misdiagnosis happens so often.
Okay, why?
It comes down to impaired proprioception.
Proprioception. So that's basically your internal body map, right?
Yeah.
Like knowing where your hand is without looking at it.
Exactly. And in EDS patients, the stretch receptors inside the ligaments are faulty. They don't send signals to the brain until the joint is already stretched way out of normal alignment.
So the alarm system is basically asleep at the wheel.
Yeah, exactly. One study we looked at by Clayton and colleagues actually tested this and found EDS patients were significantly less precise at replicating their own hand positions blindfolded.
Oh, well.
Right. And when you translate that to the pelvis, patients often literally cannot feel that their muscles are clenched. They'll be hooked up to a biofeedback machine showing massive tension, and they'll tell the doctor, I feel totally relaxed.
That is terrifying. Your own nervous system is basically gaslighting you.
It really is.
So what does this all mean for the big stuff, like surgery? If conservative stuff like Kegel's backfires, and a patient has severe issues like pelvic organ prolapse, they often turn to the surgery. But does the surgery actually hold up?
Well, this is the surgical dilemma, and it's a core focus of all this research. Because in the general population, native tissue repair, where they use your own tissue to fix the prolapse, has a historical failure rate of about 17 to 20% at 10 years.
And a general 11% reoperation rate at 5 years.
Right. Those are the baseline numbers.
Which are already kind of high. But for an EDS patient, if a surgeon does a native tissue repair, they are using the patient's own faulty, stretchy tissue to fix the issue. Isn't that essentially trying to repair a broken hammock using frayed rope?
It totally makes sense conceptually why you'd think the failure rate would be astronomical. But the actual data on EDS surgical recurrence is wildly conflicting.
Yeah, let's look at the Davidson study from the Canadian Neurological Association Journal.
Right. So Davidson and his team found that in the immediate acute postoperative phase, EDS patients had massive complications, like a 46% hospital readmission rate compared to just 10% in non-hypermobile patients.
46%, that's almost half. So they're dealing with urinary retention, hematomas.
Exactly. The tissue is clearly struggling with the acute surgical trauma. But, and this is the crazy part, when they tracked the long-term recurrence of the prolapse, they found no significant difference compared to the non-EDS group.
Wait, really? No difference at all?
None. The native tissue repairs seem to hold up over time just as well.
But that completely defies the logic of the frayed hammock analogy. How is that possible?
That's exactly why this is so fiercely debated. Because on the other side of the literature, you have groups like APOPS, the Association for Pelvic Organ Prolapse Support, and researchers like Similis and Veit-Rubin.
And they argue the exact opposite, right?
Yeah, they say that stretchy skin on the outside definitely means stretchy tissue on the inside. Veit-Rubin found a highly significant association between hypermobility and progressive mechanical failure.
Right, the idea being that the suture only gives a temporary fix before the tissue inevitably just stretches out again.
Exactly. And Similis documented severe long-term complications unique to connective tissue disorders, like synthetic mesh eroding through the fragile tissue.
Ouch. So the data is just completely split. You got Davidson saying it lasts and Veit-Rubin saying it fails.
It's very messy data, mostly because recurrence is often strictly defined as anatomical failure by surgeons. If the organs haven't dropped past a specific line, they call it a success.
Oh, I see. But the patient might still be in agony because their muscles are still overcompensating for the loose joints. The anatomy looks fine, but the symptoms are still ruining their life.
Precisely. And EDS is a huge spectrum. A study on general hypermobility might show different results than one focusing on severe classical EDS.
Okay, so if surgery is this massive gamble and Kegels make it worse, what is the actual playbook here? How are specialists treating this?
It's all about highly tailored conservative management first, and then emerging regenerative therapies. For physical therapy, the entire focus shifts to downtraining.
Right, forcing the muscles to finally relax.
Yes, they use biofeedback so the patient can visually see the tension they can't feel, and manual release to unstick the fascia. But they also heavily rely on mechanical support, like pessaries.
Ah, right, a pessary. So that's a removable silicone device that manually props up the organs, bypassing the faulty collagen completely.
Exactly. It manages the prolapse beautifully without surgical risk. But if we connect this to the bigger picture, the really exciting stuff is regenerative medicine, prolotherapy and PRP, or platelet-rich plasma.
Here's where it gets really interesting to me, because I read the notes on prolotherapy and it sounds completely backward. You inject a localized irritant, like dextrose, directly into the loose ligament.
It does sound crazy to cause intentional inflammation in an already painful joint.
Right. But the goal is to trigger the immune system, right?
Yes. The irritant basically tricks the body into thinking there's a fresh injury. That triggers fibroblasts to rush in and lay down brand new, much tougher scar tissue.
Oh, wow. So instead of stretchy, faulty collagen, you're tricking the body into building a rigid bungee cord to hold the joint together.
Exactly. You are chemically inducing the body to stiffen the ligaments. And a lot of EDS patients use these as regular tune-ups to keep things stable.
It's just brilliant. To help these patients, doctors are simultaneously using physical therapy to force the muscles to relax, while using injections to force the ligaments to stiffen up. It's a total recalibration of the pelvis.
It really is a paradigm shift. We're moving from just palliative care managing symptoms to reparative care, trying to actually toughen the flawed tissue itself.
Well, we have covered so much ground today. We've taken you, the listener, from the genetics of faulty collagen straight through the hypermobility paradox where loose joints cause rock-hard muscles. We navigated all that crazy conflicting data on surgical recurrence and finally landed on the really cool frontiers of regenerative medicine.
We did. But all of this raises a really important question that we need to leave everyone with.
Oh, definitely.
We know from clinical data that aging, and especially the decline of estrogen during menopause, naturally weakens the connective tissues of the pelvic floor in all women.
Right. Estrogen is crucial for collagen.
Exactly. So what happens when an EDS patient hits menopause? If their collagen is already genetically fragile, does this sudden drop in estrogen trigger a compounding double whammy for their pelvic floor?
Oh, man. That is a crucial area for future research.
Yeah.
And definitely something to consider if you're navigating the lifelong management of hypermobility.
Absolutely.
Well, thank you so much for joining us on this deep dive. It's a complex, murky landscape, but understanding the actual mechanics changes everything. We'll catch you on the next deep dive.